I would encourage anybody who, has time or interest, to be able to give back to the community and provide good clinical care to people who don't have access to it. It's very rewarding. A common private practice discussion that we also have at the hospital is making sure the person knows their options, making sure that they can give consent to the care that we're discussing. Sometimes there's substitute consent givers brought in. Sometimes we have the conversations with parents or relatives or things like that. But we always have to make sure that the person understands. As dentists, we do a ton of dental work where the patient doesn't perceive the problem, right? We fixed your gum disease. I didn't even know I had gum disease. It didn't hurt, right? But when someone comes in and says, oh my goodness, I've got this problem, is there anything you can do? And you can kind of treat them that way. Whether it's in a correctional facility, whether it's at a mental health hospital, whether it's at a clinic for people who don't have access to great care, that kind of thing. That's what keeps me coming back to the clinical dentistry, and I don't think I'll ever stop.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.
Welcome back, everyone, to another episode of A Tale of Two Hygienists, an Endeavor Business Media production. This is episode number 363. I am your host, Andrew Johnston. Thank you so much for being with us today. Now, before I get into the normal intro, because I'm sure you guys figured that out by now. I was like, hey, today's show, we have this. Next week, we have this, couple of words, and then kick it to the episode. But before we get into that, I just want to say, what the crap, man. Did you all see the post about this Terry from Florida, this hygienist, who's willing to take your SRP patients and give them the prophy that they really want instead? Oh my gosh. I have so many thoughts about this. I don't think that I could do better, though, in an episode than what was done in the RDH rant or Andy RDH's Facebook group. So if you have no idea what I'm talking about, you absolutely have to go check that out. By the time that this episode comes out, it's going to be about 2 weeks later. So don't be surprised if it's not still kind of, right there at the front. But it's so good. So many good things. For today, and I am so sorry for those of you who listened to last week's episode and were expecting Teresa Duncan to be on this show today, because that is what I said. You didn't hear that wrong. But what I should have told you was it wasn't that Teresa was going to be on today, but that we have this really great show planned with Dr. James Younger. Dr. Younger, he's just had this most incredible career, and he has worked in the settings that have varied, to say the least. He has a perspective of just putting people first in anything that he does. So in this episode today, we talk a lot about what his experience was working in a prison, working in a mental health institution. It was amazing. And so I think that you're definitely going to get something out of this episode. So next week, however, and I mean it this time, that Teresa Duncan will be on. And I wish I could go and like copy and paste the audio from last week and said, hey, this is what we're going to talk about, that kind of a thing. But it will be about insurances and some really important things that you need to know as we're closing out this year and starting up the next year. This isn't stuff like, oh, there's a new denture adjustment code, blah, 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 that no one cares about. It's more about the things that are affecting your patient's coverage. They're going to ask you about that, and they're going to expect you to know. One little caveat, and maybe I should probably talk about this on the intro for next week also, but Massachusetts isn't the only one doing it. And that's all I'm going to tell you about that. So come back next week. You'll hear on the intro and then also on the show with Teresa what the important news is. So the final thing that I want to talk about is I want to draw your attention to our Friday tip episodes. If you are a listener, probably more of an infrequent listener, someone who is maybe scrolling through and saw someone that you really liked, so you want to listen to that episode, and this is one of the ones that you are listening to, I have been getting a lot of the same emails and text messages about renewing or joining ADHA. I know that you all have, you probably also got those same emails and texts about renewing. And so last week, I delivered a tip episode that probably wasn't the most convincing of arguments to either be or not to be a member of the ADHA. So give it a listen. Let me know your thoughts. Andrew at tale2hygienist.com. Let me know if you're going to be a member, if you're not, and kind of why. I think it's always nice to hear firsthand, but I think you'll hear if I'm going to be a member or not. So that's it for me. Thank you so much, and I hope you enjoy this episode with Dr. James Younger.
A tale of two hygienists.
Hey friends,
quick pause in the show to remind you about the CE offered for several of our episodes. All you have to do is click into the show notes and follow the link to the CE Zoom website. Answer a few of those questions about the episode correctly, and you'll be rewarded the appropriate amount of CEUs. This wouldn't be possible without a partnership with our friends at Tempstars. Tempstars is more than just a temp and a placement service. They are clinician-led and education-focused and strive to perfectly match individuals and dental offices. Learn more about Tempstars.com or go back and listen to some of their tip episodes. They are absolutely worth the listen. And now, back to the show. All right, everyone, welcome into the interview portion of the podcast. Very excited. We have Dr. James Younger on again. It's such a smashing hit, by the way. I don't know if we gave you the numbers from when you were on before, but our audience loves you. I don't know if you know that.
Thank you.
So thanks for coming back on again.
Well, I have to say, thank you. I'm flattered to be back on. And as you know, I'm a huge fan of the podcast, and the content and the value that you're providing for the dental profession is just outstanding. So I love being a part of it, getting to know you guys, and just being a part of A Tale of Two Hygienists. So thanks so much for having me back.
Oh, heck yeah. Well, it goes both ways. You do so much for the dental community. I think, we've talked about this before, and I think the audience, they probably don't care about this part, but I think it needs to be said. Anytime that we've had conversations, you're always so selfless. You're saying, well, I don't need to talk about my things. I don't need to push my product. I just want to just help other people. And I think that's why we always want to be a part of whatever you're doing. So, but you're also taking a part of your day, like you're stepping away from a really important meeting right now. So I appreciate your time. What are you up to right now?
Oh, yeah. And so a shout out, I'm actually at Great Wolf Lodge with my family, but the Illinois Dental Hygiene Association annual convention is here. So Tempstars has a booth there. I've been meeting fantastic people from the leadership of the Illinois Dental Hygiene Association, but also the members, and just really getting to know people, getting to a real feel for an understanding of what's on the minds of dental professionals in Illinois, and also just really getting to know the leadership and building relationships. So it's been a great weekend. I'm so happy to be here, but of course, happy to take some time out for this. I mean, a pleasure.
Yeah, absolutely. So, by the way, just as another aside, just because that's how we do things, Illinois, they have had some very interesting legislation battles in the last several years. So if you have a chance to talk to leadership about some of the things that have been coming through, I think it's fascinating to discuss. Obviously, we're not going to get too much change at this meeting, but it's fascinating. So if you get a chance to do that, that'd be great.
Well, I've heard mentions of that as a topic, but having not dug into the details yet. But that's a great point. I think I will ask. I'll ask around about that to see what's happening.
Yeah, I mean, and they're such good advocates there. Okay, so the idea for this episode was based actually upon some of your just past experience as a dentist and working in different facilities. And I don't really have a game plan for this one, so I guess I want to lean into your passions.
Sure.
You've worked in a couple of different facilities. If you would maybe give us a little bit of background again about that, and then we can just go in whatever direction your heart follows us.
Yeah, happy to. So, I mean, my professional background, I'm still a practicing dentist. I've owned 2 different dental practices. One I had started from scratch as a build out and grew that for 5 years successfully. And then after that, I purchased and ran a very high-end cosmetic full mouth reconstruction practice. Was doing, sinus lifts, bone grafting, implants, full mouth reconstructions, that kind of thing, and loved that. And then also sprinkled throughout there, and what I'm currently doing is I do clinical dentistry at a mental health facility. I've also worked in corrections, and it was through the pursuit of growing Tempstars that I did end up selling the cosmetic dental practice. And at the time, and of course my colleagues would say, well, you have this crazy idea for this thing and you sold your practice. Wasn't that risky? And really the way I was thinking about it was the opposite, in that I love owning a dental practice and I love leading a team and I love clinical dentistry. And I thought, well, in launching and growing Tempstars, if anything ever happened where I was barking up the wrong tree with it, then I would just happily go back and start another practice, buy another practice, grow another practice, that sort of thing, without any fear or hesitation. And I kept setting myself benchmarks for, as Tempstars would grow, I would say, okay, well, if it's not doing this by this time, you're barking up the wrong tree, you just go back and do clinical dentistry. And I'm really happy and pleased and excited to say that it just, as I started setting those benchmarks for myself for achievement, it just kept surpassing that. Mm-hmm. But knowing that I love clinical dentistry, I was always looking for ways to keep my hands in clinical care. And so now I'm working out of a mental health facility. But I also do volunteer dentistry at a clinic for the homeless. And so I would encourage anybody who's, has time or interest, to be able to give back to the community and provide good clinical care to people who don't have access to it. It's very rewarding. And I love doing that part of it too.
Oh my gosh. So we have, I mean, I guess like 3 buckets to choose from at this point. You know,
Sure.
So maybe let's start right. So right after, actually, let me, before that, which of these was first? What happened? Was it the correctional facility? Was it working with the homeless? What one happened first?
Well, so early on in my career, so I think I'm on to 23 years now as a dentist. And so in, let's say, the first 5 years, I was associating at a practice, but also that was just part-time. So then there was an opportunity to work at a mental health hospital at that time. So I took up that opportunity. And then just by coincidence, next door was a very large correctional facility and they were looking for somebody. And so, and I like, there's an aspect to institutional and community health dentistry that I do like. And so at that point, I took a little hiatus from private practice and I was splitting my time between the correctional facility and the mental health hospital. And then I did that for maybe 5 years. And then I was kind of getting the private care itch again. So that's when I started the practice from scratch and grew that. And then I had the high-end practice. And that's when I got the idea for Tempstars. And so once I had transferred ownership of the cosmetic dental practice, that's when I kind of just reached out to see if the mental health hospital was looking for any dentists or that sort of thing. So that's sort of how I got back into doing that, to make sure I could provide clinical care as I helped to grow Tempstars. And then from there, just through meeting different people and being involved in different charitable events, that's when I got connected with, it's called Filling the Gap Dental Care. It's out of a clinic called Urban Dental. And that's how I got involved in the volunteer dentistry and really love doing that as well.
I like that name, Filling the Gap.
Yeah.
A little play on words. Okay,
Right.
so let's talk first about your first stint with the mental health facility. So, I mean, were you just walking down the street and you saw like hey, we need a dentist in this building? How did that part come about? How did you learn about that opportunity?
I think, to be honest, the way I heard about it, I was associating at a practice at the time, and it was probably one of the dental supply company representatives who was in the office and just spreading the word around, because the mental health hospital isn't in a major center. It's more in a smaller community. And so it's not as though they have a huge pool of dentists local to that facility that are available to work there. There are some, but most of them are just fully occupied in their private practices. So they were extending the reach and the opportunity further out, and I'd heard about it. And so I called in and met the people and saw the facility and things like that. So that's kind of how I got involved with that.
So you're going to have to forgive a lot of my ignorance for this whole entire
I'm happy
podcast.
to. I love talking about this.
Here's the question I have. So the makeup of the types of patients that are there, is this all inpatient? This is patients that are coming and going? Like what does it look like?
So the population from the first time I had worked there to currently, and even post-COVID, it's evolved a bit. So when I first started working there, and this would have been, I'm just guessing, ballparking 15 years ago, say, it was a mix of inpatients and outpatients. And interestingly, and relatively unique to this facility, is there is a segment of the population that are inpatients and what we call the provincial population, meaning they've been there and they're, I guess, considered a danger to themselves and to others. And so it's more of a maximum security setting. Now, it's still within the same facility as more community-based mental health challenges. And we were seeing kind of an outpatient base of community and inpatients. And then there was a population as well that we were seeing that was under maximum security situation. And so that was kind of the 15 years ago one. Yeah. And so that there was a completely separate facility. That was where the people who were under maximum security protection were. And so I would spend some time there and some time in the community-based clinic. And so then when I went back to private practice and then returned to the mental health hospital, still the same mix, except post-COVID, because of initially COVID restrictions, but then just backlog of patients, we ended up that we weren't able to see as many outpatients as we normally could. And so we really are now just seeing inpatients at the facility, where it's people with kind of more community-based mental health challenges that are inpatients there, as well as the maximum security population as well.
Were you seeing different prevalent rates of diseases, caries, perio, based on I guess those groups, the maximum security group versus the ones that are, inpatient versus the ones that are outpatient? Are you seeing different levels of disease?
Not in any kind of obvious association. Inpatient hospital populations have a lot of oral health challenges. And also when you compound on that mental health challenges, oral health often is not what it could be. So we really try our best. We have a dental hygienist, we have a denturist, and myself as the dentist. And we really try, it's a mix of just addressing the current dental disease, gum disease, caries, infections, things like that, and trying to get people as well as possible on a maintenance program to maintain their health. It's challenging. Some people aren't just able to maintain their own optimal health. They want, some won't. And just like every population, there's certainly some that just aren't that interested in maintaining their oral health. And some rely on the staff who work at the hospital to maintain their oral health. And again, a busy staff, a busy nursing staff and support staff who have 100 things to do every day, do they have the time to brush and floss every person's teeth properly who aren't able to do it themselves? I think that's a big ask of anyone. So we're always just there to really do everything we can to just address the disease and as well get people on a maintenance program as much as possible. But to answer your question, I don't think I've noticed any clear distinction or association between, say, what would be considered the protective side of things versus the community-based mental health side of things. I think it ends up being caries, infections, gingivitis, periodontitis, that sort of thing.
I absolutely feel for the individuals that are working with the patients. You're right. They have too many things on their plate, and they're just trying to do their best to keep people happy and healthy and safe. But I guess to that end, I mean, are they also educated in the same way? Do you guys have in-services with the teams that are working with the patients, right, that are non-dental professionals to help with home care, or how are they trained / educated for oral health maintenance?
That's a great point, Andrew. And I'll admit there's probably a lot more that we and the facility would be able to do with that. We did in the past, we would have our dental assistant go to the different units and show the nurses and the support staff how to brush teeth and what proper oral health care is and things like that. We haven't been doing that as much as we could lately. We're still recovering from kind of a backlog of COVID patients because everything got paused as the dental clinic got shut down. So we're still kind of working through our backlog that way. But I think from a preventive standpoint, that's a huge thing. It's one component, right? Because at one point, everybody has to know the right thing to do. And then you have to layer on top of that the opportunity and the time to do the right thing that they know to do too. So it's kind of a two-pronged challenge. But you're 100% right. There's more of an opportunity as we're coming out of post-COVID to kind of address that education for the support staff on the units as well.
I can just imagine they're emotional, like they're being pulled in a million different ways. I wasn't trying to blame anyone for not doing anything. Right. It's got to be tough. It's got to be really tough. What about, I guess the different security levels, home care tools? Do they, are they allowed to have certain things and not allowed to have certain things for home care in, maximum security versus, like the outpatient, which can, I assume, have everything?
Yeah, for the most part. And the people who are under the higher levels of security, it depends on, I guess, what would be considered their levels of permissions of sorts or their levels, that sort of thing. Mm-hmm. So there are certainly some very long-term patients there who 10, 15, 20 years have never caused any kinds of problems and are fairly integrated into that system and things like that. And they might have a higher level of access and permissions versus somebody who may not be so well, might be struggling more with their mental health challenges or things like that. So I think from a system standpoint, what they have access to depends on the assessment by the doctors and the nurses and the staff and things like that. I don't think anybody has floss in the maximum security side. So I could probably say that I don't think they have access to floss. Certainly toothbrushes, yes. But I think from a flossing standpoint, I don't recall anybody having access to floss.
And this is conjecture, but would you think that they could probably have interproximal brushes? Would that be all right? Or would that the wire be like...
Yeah. I wonder, so because there are certain... And you have to remember, the patients live there 100% of the time. So it's one of those reflections of how a society takes care of their vulnerable populations. And yes, they're under security restrictions, but, they do have shop class and they do have art and they have things they can do during the day. And there used to be, and I don't know to be honest now, but there used to be a very extensive woodworking shop. And so you could order a nice dresser, and there were some very skilled carpentry craftsmen in that population. You could order beautiful furniture and things like that. So, and again, it depends on security levels and things like that, and people's access and privileges and all of that sort of thing. So I can't imagine inherently that interproximal brushes would be necessarily restricted, but I don't know. I don't know who would have access to those right now.
Sure.
Yeah.
So I'm curious, our everyday patients that call up, say, hey, I need an appointment, or we scheduled it 6 months out already and the date comes. Mm-hmm. How is the triaging or how is the setting of appointments occurring in this facility?
Yeah, so we have a booked schedule. So when I arrive, there's a schedule of patients, and I can tell you, and I guess this matters. My compensation for working at the hospital is a per diem. So I am not incentivized by, we have to grind through as much production as we can. And I don't get frustrated if we have to reschedule people if they're having a bad day, or if somebody decides this is not the day I want treatment done or anything like that. So there's nothing about my treatment planning, the way I approach care or anything like that, that is incentivized in any way through income or profit or anything like that. I'm there to spend the day caring for the patients, to address them in a patient caring way as they need to be treated and things like that. So we have a schedule for the day. We try to get down the schedule, but everybody's there, so nobody's saying they're stuck in traffic or that sort of thing. But some people have better days and worse days and things like that. They can come down, or maybe they have an appointment schedule with another physician or something like that. So we approach it from a standpoint of, we have a schedule, we try to stick to the schedule, but we're very flexible about it. And sometimes we have to shuffle people around. Sometimes I come in for the day and we've got notes from 3 different doctors that their patients might have tooth abscesses or things like that. So we shuffle things around and make sure that we're addressing urgent care, infections, pain, and things like that. We prioritize those for the day and then kind of keep working through our schedule. Once that's done, if it's an emergency thing, kind of like a typical private practice where you'd say, okay, well, we took care of this why don't we see you back in a couple of weeks to do a full assessment and see what other things that you might have going on and that sort of thing. So I would say, yes, it's scheduled, but it's we keep it fluid based on the needs of the day.
Yeah, absolutely. All right. Another question.
Yeah.
I feel like I have all these questions tapered out.
I love it.
Technologies, tools. Are there any modifications that you need to do? Things that you may be working differently than you would in private practice?
No, I would say from a facilities and technology and tools and instrument standpoint and things that we do, we have all of we have digital x-rays, we've got, rotary endo, things like that. We don't have a full suite of care available in terms of, we don't do crown and bridge or implants or veneers or things like that. It's kind of a, extractions, restorative, some endo, and endo, we just have to make the decision about endo, because sometimes we could say, well, this tooth could be saved with a root canal, but all the other teeth are also extremely decayed, and it might be more worth our time doing more restorative care or triage or extractions and prost or something like that. So certainly there's a ton of informed consent. And, if you want one aspect of that is always top of mind is informed consent and decision making too, right? Because of a common private practice discussion that we also have at the hospital is making sure the person knows their options, making sure that they can give consent to the care that we're discussing. Sometimes there's substitute consent givers brought in. Sometimes we have the conversations with parents or relatives or things like that. But we always have to make sure that the person understands. And also there's times where somebody might be in the hospital on a short-term basis. Yes, they're inpatient, but there could be a plan to have them back into the community. And so we can say, well, this is what we can offer here. But if you think that you'll be back out in the community a bit, if you were able to see a private practice dentist, you would have these other options available to save the tooth. So if you want the tooth extracted today, I'm happy to do it, but I don't want you to think that that's the only option. It just happens to be the only option today in this clinic, but there's other options in the community. If we can stabilize things for you now and you want to save the tooth, then we can kind of make arrangements otherwise.
So how do you have all that information? Is it dentistry? We have, the one dental record, and then maybe whatever referrals might have shown up at our office. But I would guess that if you have access to more medical professionals, what does your chart or record keeping look like?
Yeah, so we use AbleDent, which is just our practice management software is AbleDent. So we keep our typical dental records, x-rays, everything on there. But there is a centralized health record that every touch point that this person has through the healthcare system and any healthcare touch points within the hospital setting are recorded in a completely separate system. So I make 2 copies of notes and I have access to 2 sets of records. So I've got my dental notes, but of course those get basically copy and pasted and reconfigured a little bit back into their central health thing. And the communication, the staff and the doctors at the hospital are very accessible. And so we have chats and that kind of thing. But ultimately, the idea of informed consent is a decision I have to make myself, that I am trained to make and I feel comfortable making, but I know the criteria to make that judgment call. And as we know, informed consent is procedure-based. You can't paint someone with a paintbrush and say, this person cannot give consent or this person can give consent. It's for that specific thing. So if I can explain to somebody and they're able to repeat it back to me in a way that I believe they understand, and they say they understand, and there seems to be objective criteria and subjective criteria for being able to consent to a filling, then we could do that, because you've also got that idea of what a reasonable person consent to this as well. And so you've got all these different criteria, and you can say, yeah, we'll do a filling. But that same person, would they be able to comprehend if we pull out all your teeth and give you dentures? That's a different level of treatment. The person might not understand all of the full implications of that, so we might loop in family or substitute consent givers or that kind of thing, depending on their level and ability to kind of comprehend that level of treatment kind of thing.
I do want to move into the correctional institution, but is there anything else that we need to know, first of all, about the mental health facility before we move on to the next?
Yeah, well, I'll tell you my core philosophy, and for anybody who might be working with patients with mental health challenges in any environment, the philosophy I use, and I think it's an important approach, is what I just, in my head, I call it extreme consent, meaning I kind of very fundamentally go back to sometimes what they, in pediatric dentistry, the tell, show, do. But even from the very get-go, when no matter what the schedule is, this patient might be coming in, we've got this filling booked in, but first, I don't get too close to the chair because I don't want them to sense that I'm about to do something. I'm a comfortable, couple feet back, and I just say, oh, hey, how you doing? And in the schedule for today, we've got this scheduled, but if you have anything else that feels more important to you, I'm happy to look at that instead. If you're in any discomfort, we're happy to look at that as well. And also, you never have to worry about me doing anything that you don't want done. So how does that sound? And then the person might have a different concern, and you have to stay flexible about that, or they might say, yep, that sounds good. And then I just say, okay, well, I'm about to lean the chair back. That okay? Are you okay to go all the way back? And so every single step, I don't make an assumption. And so everything is first permission-based, and then I do the thing, right? And every part of it is permission-based. And so I know because, and it happens, patients could reach a point where, oh, I wasn't ready for that. I didn't know that. And I've let them know ahead of time. And they're like, you know what? I'm not feeling up to this today. Can we do this another day? And I say, yeah, no problem. But the mistake is making assumptions, getting too far deep into, say, an extraction, and the person, it wasn't ready for it, and now you've got a tooth halfway pulled out or something like that, and now you're in it. So you have to make sure that you've got permission for every single little step along the way. You build that trust, and the appointments go a lot more smoothly that way, because at any point, if somebody says, I'm not ready, or no, I didn't know it was that, then perfectly okay. Let's do this another day or figure out another strategy. So I think that really does help for me and our team and the patients. The day goes more smoothly that way, because we never run into a point where I'm making an assumption or imposing some treatment on somebody or making an assumption or things like that.
Gosh, I love that. It's the right way to treat people. Okay, so what are the big differences, now moving on to the corrections facility?
Yeah.
I think Bethany might end up shining on this one too, because I know you have a lot of experience with this too, but what are the different considerations? Let's talk about, again, the populations types, the prevalence of disease, like the same kind of things. What are we seeing differently here?
Well, I'll tell you, and of course, this is just speaking in generalities, and it's probably been 8 or 10 years since I practiced in the correctional facility. I can't imagine there's a ton of changes, but I tell you the way the clinic worked at the correctional facility I was at. So I think that there is often overlap between mental health challenges and the correctional system, but not necessarily and inherently. So in general, I would say for people in the correctional facilities, for the most part, they can clearly give consent for the treatment. Also, they're often coming in from somewhere outside in the community somewhere, and maybe sometimes from living on the street, that sort of thing. So often they'll have immediate concerns that are most often addressed just with an extraction. It's also a very fluid population, so you don't know if they're in or out that day, if they're just there on remand, if they've been sentenced, if they have been sentenced, are they going to a different facility, that sort of thing. And so for the facility I worked at and the clinic I ran, it was essentially, if I had to boil it down, it was a palliative and extraction walk-in clinic. So somebody would come in, I'd say, what's going on? We can do one thing today. They're like, I want this tooth out. I'm like, fantastic, consent, get it out, see ya. And so we didn't have, in that setting, we didn't have a schedule because everything was so fluid, and we had, it was just me there, and I can't remember how many thousand of patients were there. And so we would just maybe see 18 people a day as basically a flow-through, walk-through clinic. If they said, I don't want this tooth out, can't you patch it? I put some glass ionomer in there or do a little scoop out and patch kind of thing and let them know it's not definitive and then see the next person. But so it's very volume-based. And I would say that from a general dentist standpoint, I've probably extracted way more teeth than the average general dentist. I've pulled thousands of teeth. And just because of that was the thing that would address that concern at that time. And we just didn't have the time for kind of comprehensive treatment planning. So I guess that would be one of the core differences there. Bethany, do you have any thoughts on that?
Well, I did some of my externship during dental hygiene school at a mental hospital, and then I worked for about 2 years in corrections before I even got into dentistry. So I don't have experience as far as like the dental practice in corrections goes, but one thing that I feel like was pretty different between those two scenarios is, in mental health setting, your patients are mainly coming to you because it's just on the schedule for their routine care. Whereas in corrections, a lot of those inmates are lining up to get into the dental clinic that day because it breaks up the monotony of their day.
Fair enough,
yeah, like it gives them something to do and something to look forward to. And so that's one thing that I remember from working in that environment, how inmates would really look forward to like small things like that, like being able to go and get their teeth cleaned or get, dental treatment too. So it's interesting.
That's an interesting take. I mean, we've all seen, in private practice, people are like, no offense, but I kind of hate you guys. I mean, this is like a control, like they want to see you. They want to, that's right. I can't wrap my head quite around that thought. That's too many years of conditioning in the other way.
Right.
Oh, that's so interesting.
I'll also flavor that with one thing that just as I was thinking. So typically at the correctional facility, I wouldn't say typically, but if people are coming in from the street or from the community, I would think it's fair to say, I would see more common occurrences of trauma, broken teeth, broken jaws, things like that, but also drug-related oral health problems. So there would be a substance addiction problem that would certainly affect teeth and all the entire dentition would be full mouth caries and things like that. So it's less likely that someone as an inpatient at a mental health hospital would have an ongoing street drug addiction problem because they're under the care of the hospital, but somebody coming into a correctional facility for the first time, they have a whole background of different things that could have been going on and things like that could affect their teeth and their oral health.
I'm going to put you on the spot a little bit, Doctor.
Yeah.
As we're kind of closing this down, I want to know like your best wins, your best success stories, the things that made you feel good about what you were doing. And it could be in either location or even at the homeless facility.
Yeah. The general theme is when I'm able just to help somebody and pain relief. And when somebody has something going on that they can't sleep or they've had a problem and you're able to address that in a caring, patient way that kind of gets them through the appointment with patience and they know that someone who cares about them has worked on them and that I've helped them with whatever concern that they've perceived. Because it's one thing, and as dentists, we do a ton of dental work where the patient doesn't perceive the problem, right? We fixed your gum disease. I didn't even know I had gum disease. It didn't hurt, right? Right. But when someone comes in and says, oh my goodness, I've got this problem. Is there anything you can do? And you can kind of treat them that way, whether it's in a correctional facility, whether it's at a mental health hospital, whether it's at a clinic for people who don't have access to great care, that kind of thing. That's what keeps me coming back to the clinical dentistry. And I don't think I'll ever stop doing that part of it because I just find it so internally. I love Tempstars. Tempstars hits every one of my buttons. I wake up every morning excited to grow Tempstars, but that aspect of the clinical dentistry of just having had a career where it does feel like I can provide some good value to patients by a certain philosophy of care and a level of patience and a level of clinical skill and things like that, it just keeps me coming back to that as well.
I love it. Doctor, thank you so much for being on again. You have a lot of places where people can find you, but what's the easiest way for people to reach out to you or learn more about Tempstars or whatever your passion is?
Yeah, well, Tempstars.com. We're expanding across the U.S. in terms of our temping service. So Tempstars.com is a great way just to check us out. Our homepage talks about all the great, unique things are there about our version of dental temping and the reason why we're growing so successfully. And then through there's a contact page. So you can certainly reach me through there if you have any questions about that. Our team will be able to get a hold of me and I'll be able to get back to you that way.
I love it. Thank you, Doctor. And we'll also put in the show notes a link to our other episode where we talk all about it and how amazing it is. So I'll be
Perfect.
sure to put that one in. Again, thank you so much for being here.
Yeah, this is a tale, oh yeah, a tale of two hygienists. So there might be only one, bringing the best of dental knowledge, and we do it all with ease. We cover oral health and screening, and preventing gum disease. We're gonna do a lot of learning, and have a little bit of fun working at the dentist. A tale of two hygienists.